ازيكم عاملين ايه؟ اهلا بيكم في PodBites where we break down complex medical topics into bite-sized pieces مناسبة للتنقل أو وقت القهوة أو لو جالكم فضول. I'm Mohammed and today I'm joined by Abdulrahman Farahat. هنتكلم النهاردة عن adrenal glands.
أهلا يا عمرو. This one's a big deal. The adrenal glands regulate everything from blood pressure to stress, sugar, salt, and reproductive hormones. When they go off track, they really go off.
For today's episode, we'll walk through adrenal hyperfunction like Cushing and Conn syndrome, then move on to hypofunction like Addison's disease, and even touch on congenital and neoplastic disorders like pheochromocytoma and Min syndrome.
And don't worry, we've got full patient cases, diagnostic clues, and practice questions to lock it all in like we always do.
Okay, before we jump into the drama, let's quickly set the stage. What do these glands normally do?
So, the adrenal gland has two major parts, the cortex and the medulla. The cortex makes steroid hormones and is made up of three zones. And since the adrenal glands are above the kidneys, remember GFR. G for glomerulosa makes mineralocorticoids like aldosterone. F for fasciculata makes glucocorticoids like cortisol. And R for reticularis makes androgens like DHEA.
So remember the GFR mnemonic, plus the fact that these hormones are organized by alphabetical order. A, aldosterone, C, cortisol, D, DHEA.
Yep, that's a nice one. So that was the cortex. Then we have the medulla, which makes catecholamines like epinephrine and norepinephrine.
Okay, so what else should we know about the basics?
Control of cortisol happens via the HPA axis. The hypothalamus releases corticotropin-releasing hormone, or CRH, which stimulates ACTH from the pituitary, which stimulates the adrenal cortex to produce cortisol.
Beautifully laid out. I think we're ready to jump into our first case. Spoiler alert, this patient is bringing some cortisol baggage with her.
Okay, a 36-year-old woman comes to the clinic with progressive weight gain over the past year. She says her face has gotten rounder, her clothes don't fit around the waist, and she bruises easily. She's also been feeling weak, even walking up the stairs feels hard. She has irregular periods and mild facial acne. On examination, her blood pressure is 158/94. You notice purple striae on her abdomen, facial fullness, and a dorsocervical fat pad. Lab shows fasting glucose of 212 milligrams per deciliter.
All right, the essential obesity, purple striae, high blood pressure, and the moon phases, this all are symptoms of Cushing syndrome, right?
Wahsh. Cushing syndrome means chronic hypercortisolism, regardless of the cause. It can be ACTH-dependent, either from a pituitary adenoma, aka Cushing disease, or ectopic ACTH, like small cell lung carcinoma. Or it could be an ACTH-independent from an adrenal adenoma, adrenal carcinoma, or even long-term exogenous steroid use.
So, what's basically driving all her symptoms is the excess cortisol?
Right. Excess cortisol leads to fat redistribution, which leads to central obesity, moon face, and a buffalo hump, muscle breakdown, which leads to weakness, skin thinning, which manifests as bruising and striae, insulin resistance, which causes hyperglycemia, and finally, it can cause immunosuppression, osteoporosis, and psychiatric symptoms.
Okay. So, what is the best way to confirm the diagnosis?
Okay, you have three first-line screening tests. Low-dose dexamethasone suppression test, where normal people suppress cortisol, but Cushing patients don't. Late-night salivary cortisol, if it's high at night, that's abnormal. Or 24-hour urinary-free cortisol, where high levels suggest Cushing.
So, based on these results, we'll know whether cortisol is high or low. But if it's high, how do we know for sure what the source is?
Mumtaz. Once you confirm a high cortisol level, you check ACTH. If ACTH is low, it's an adrenal cause. If ACTH is high, it's either pituitary or ectopic. And for this, you use high-dose dexamethasone to tell them apart.
That does make sense. Because if cortisol is high, the normal response would be a negative feedback to the pituitary, causing a decrease in ACTH. So if ACTH is still high, this tells us there's either a problem with the pituitary itself that's not allowing it to respond, or as you said, ectopic secretion of ACTH, which also would not respond to this negative feedback mechanism. And if cortisol is high despite ACTH being low, this tells us the problem is clearly not from the pituitary, and the adrenal itself must be producing more cortisol.
Ash, perfect explanation.
So let's say it's a pituitary adenoma. What's the next move?
Okay, so surgical removal, definitely. Specifically, a transsphenoidal resection. For adrenal adenomas or carcinomas, you go for an adrenalectomy. And if it's ectopic ACTH, like from a lung tumor, you have to find and treat the primary source.
All right, listeners, here's a quiz to make sure you understood. A woman with features of Cushing syndrome has high cortisol, low ACTH, and no suppression with dexamethasone. What's the most likely cause? A. Pituitary adenoma. B. Ectopic ACTH secretion. C. Adrenal adenoma. D. Iatrogenic steroid use.
And the answer is C, adrenal adenoma. Low ACTH means ACTH independent, and lack of suppression confirms it.
All right, next patient, please. Let's talk about a sneaky cause of hypertension.
Okay, a 40-year-old woman visits your clinic for evaluation of high blood pressure. She's on 3 antihypertensive medications, but her blood pressure today is still 170/102. She mentions frequent muscle cramps and says she's been feeling tired and lightheaded. Vitals are normal aside from blood pressure. Labs show elevated sodium, low potassium, and high bicarbonate.
So, from what I'm seeing, hypokalemia and resistant hypertension. This makes me think of primary hyperaldosteronism.
Bingo! And when it's caused by a unilateral aldosterone-producing adenoma, that's called Conn syndrome. You can also get bilateral adrenal hyperplasia.
And aldosterone acts on the distal nephron to reabsorb sodium and excrete potassium and hydrogen. Is that right?
Mumtaz. So you get hypertension, hypokalemia, and metabolic alkalosis.
Okay, Farahat. How do you confirm it?
Okay, so let's start with the aldosterone to renin ratio. It will be high, meaning aldosterone is high and renin is low. Then do a saline suppression test, where an isotonic saline solution is given to the patient. If aldosterone does not get suppressed, that confirms primary hyperaldosteronism. This is because in a healthy person, the volume expansion caused by saline would suppress aldosterone secretion.
So, is there a role for imaging here?
Of course, imaging with CT or MRI helps localize a tumor.
And how are these treated?
If it's an adenoma, you go for surgical resection. If it's bilateral hyperplasia, use mineralocorticoid receptor blockers like spironolactone.
Okay, test time. Again, which of the following lab abnormalities would you expect in Conn syndrome? A. Hyponatremia. B. Hyperkalemia. C. Hypokalemia. D. Metabolic acidosis.
And the answer is C, hypokalemia. It's a classic in primary hyperaldosteronism.
Wonderful. Take us to our next case.
Okay, now a 42-year-old woman presents with 3 months of fatigue, weight loss, nausea, and dizziness when standing. She says she's constantly craving salty food. You notice hyperpigmentation over her knuckles and gums. Blood pressure is 85/55, heart rate is 96, labs show low sodium, high potassium, low glucose, low morning cortisol, and elevated ACTH.
Oof. Fatigue, salt cravings, low blood pressure, and that bronze skin. That screams Addison's disease.
Wahsh! This is primary adrenal insufficiency, where the adrenal cortex is destroyed or dysfunctional, causing a deficiency of both cortisol and aldosterone. The most common cause in developed countries is autoimmune adrenalitis, but infections like TB or fungal disease can do it too.
Like, Farahat, how can we relate these deficiencies to the patient's presentation?
The lack of cortisol causes hypoglycemia, as cortisol normally promotes gluconeogenesis, weakness, and hypotension. While the lack of aldosterone causes hyponatremia, hyperkalemia, salt craving, and volume depletion. And because the adrenals are failing, ACTH increases, which causes hyperpigmentation, as ACTH shares the pro-opiomelanocortin precursor with melanocyte stimulating hormone.
Not gonna lie, that's a great distinction. Hyperpigmentation is a unique giveaway for primary, not secondary.
Yep. So, to summarize, the key labs are low cortisol, high ACTH, electrolyte disturbances including hyponatremia and hyperkalemia, and you confirm with the cosnitropin ACTH stimulation test, where no cortisol response is indicative of primary.
Farahat, you defined the disease, you mentioned the pathophysiology. Can you go about how do we treat Addison's disease?
Okay, they'll need lifelong steroid replacement, hydrocortisone or prednisone for glucocorticoid replacement, fludrocortisone for mineralocorticoid replacement, and during illness or surgery, they'll need stress dose steroids to prevent adrenal crisis.
Pop quiz. Why does hyperpigmentation occur in primary adrenal insufficiency? Is it A, low cortisol stimulates melanocytes? Or is it B, autoimmune skin reactions? Or is it C, excess aldosterone triggers skin changes? Or is it D, ACTH overproduction leads to increased MSH?
And the answer is D. ACTH overproduction leads to MSH activation. That's why it's unique to Addison's disease.
Whoa. Okay, next up, same symptoms but without the skin changes. Let's talk about secondary and tertiary insufficiency.
Okay, let's go. A 60-year-old man presents with fatigue, low energy, and poor appetite. He was recently tapered off long-term prednisone for polymyalgia rheumatica. On examination, his blood pressure is 90/60, pulse is 90, but there's no hyperpigmentation. Labs show low sodium, normal potassium, low cortisol, and low ACTH.
So we've got low cortisol, low ACTH, but no hyperpigmentation nor hypokalemia. I feel like this is secondary adrenal insufficiency.
Mumtaz. Secondary adrenal insufficiency happens when the pituitary doesn't make enough ACTH. Tertiary is when the hypothalamus isn't making enough CRH, often due to sudden withdrawal of chronic steroid use.
But how do we differentiate it from Addison's disease?
Here's the key differences. The adrenal glands are intact, but there's no ACTH stimulus, so cortisol is low. But aldosterone stays normal because that's regulated by the RAS system, not ACTH.
يعني no hyperkalemia and no skin changes, unlike Addison's, right?
Yep, ممتاز.
طب فرحات, what are some diagnostic clues?
Low cortisol and low ACTH is the giveaway for diagnosis. Electrolytes are milder. You might see hyponatremia from cortisol's role in water balance, but potassium stays normal.
And what is the difference in treatment between primary, secondary, and tertiary insufficiency?
The main difference in treatment is just glucocorticoid replacement. No fludrocortisone need.
And remember, guys, to double the dose during illness.
Yep. Thank you for the reminder.
No problem. Quick question. Which of the following would help distinguish primary and secondary adrenal insufficiency? A. Low cortisol. B. Low ACTH. C. Hyponatremia. D. Presence of eosinophilia.
And the answer is B. Low ACTH. In Addison's, ACTH is high, but here it's low because the problem is higher up in the pituitary or hypothalamus.
So, 4 solid segments down. Coming up next is congenital adrenal hyperplasia, adrenal tumors, and everyone's favorite, pheochromocytoma.
Okay, now, a 4-day-old female newborn is brought to the emergency department by her parents. She's been vomiting repeatedly, seems very sleepy, and hasn't been feeding well. On physical exam, the baby is hypotensive, dehydrated, and has ambiguous genitalia. Labs show low sodium and high potassium, hypoglycemia, and markedly elevated 17-hydroxyprogesterone.
Okay, so let me give you my analysis. So, ambiguous genitalia, salt wasting, and that sky high 17-hydroxyprogesterone in a newborn. This all makes me think of congenital adrenal hyperplasia.
شغال. Congenital adrenal hyperplasia is a group of autosomal recessive enzymatic deficiencies affecting steroid hormone synthesis. Most cases are due to 21 alpha hydroxylase deficiency.
So it's congenital because there is a genetic deficiency of 21 hydroxylase. And when this enzyme is deficient, you can't make cortisol or aldosterone. But why is it called adrenal hyperplasia if we can't make the hormones?
Since there is decreased cortisol, the anterior pituitary starts making so much ACTH, which stimulates the adrenal gland and makes it bigger. That's why you see adrenal hyperplasia in the name.
Okay, so it is because of low cortisol. What about the low aldosterone?
In classic forms, like our patient here, the low aldosterone leads to salt wasting crisis. Basically, they lose so much salt and water and become hypotensive.
So, since the rest of the precursors of these hormones can't go the way they should, they just go to produce androgens instead?
Yep. With the pathway blocked, steroid precursors are shunted into the androgen pathway, leading to virilization. In females, this can present with ambiguous genitalia. In males, they look normal at birth but develop early virilization and puberty.
So, these babies may have hypoglycemia because of low cortisol and ambiguous genitalia if it's a girl. And their electrolytes reflect the aldosterone deficiency with low sodium and high potassium.
Perfect. You got it.
So, you said something about the classic form. Do we have a non classic form of this deficiency?
Yes, 21 alpha hydroxylase deficiency may be classic or non classic. The key is that classic 21 hydroxylase deficiency is severe and presents in infancy with salt wasting, hypotension, and ambiguous genitalia. And the diagnostic marker would be elevated 17 hydroxyprogesterone. However, the non classic 21 hydroxylase deficiency is milder with a later onset and presents in childhood or adolescence with hirsutism, acne, irregular menses, or early puberty.
The most common deficiency leading to congenital adrenal hyperplasia is in 21 hydroxylase, but we can also have a deficiency of other enzymes in the steroidogenic pathway.
Yes, another possible deficiency is 11 beta hydroxylase, which would also cause virilization. But the difference here is that you have the accumulation of a specific precursor, which is deoxycorticosterone. And when deoxycorticosterone builds up, it acts like aldosterone. So you get hypertension and not salt wasting.
Oh, so in 21 hydroxylase deficiency, you have salt wasting and hypotension, but in 11 beta hydroxylase deficiency, you have a mineralocorticoid effect leading to hypertension.
Exactly.
Since we have specific precursors building up, those can help us in the diagnosis, right?
Yes, those can be helpful specifically in 21 hydroxylase deficiency, where you can see elevated 17 hydroxyprogesterone. Other than this diagnostic marker, you can diagnose 21 hydroxylase deficiency by checking the electrolytes, which would show hyponatremia and hyperkalemia, and also by finding low cortisol and high ACTH. Plus, you would see the ambiguous genitalia.
So, logically thinking, you have to replace all these deficient hormones when you're treating them.
Yes, so you replace their cortisol by giving hydrocortisone, and this would suppress ACTH to calm down the adrenal hyperplasia. Then for the salt wasting forms, you give fludrocortisone, which is basically aldosterone as a drug. Sometimes you may need to supplement these neonates with some salt, and for the virilization in females, surgery may be needed.
But luckily, though, with lifelong management, the prognosis is generally good. Now it's time for a quick question. Which of the following is the most likely lab marker in classic 21 hydroxylase deficiency? A. Low cortisol and low ACTH. B. High 17 hydroxyprogesterone and hyperkalemia. C. High aldosterone and hypertension. D. Elevated deoxycorticosterone and metabolic alkalosis.
And the answer is B. High 17 hydroxyprogesterone and hyperkalemia. That's the hallmark of classic congenital adrenal hyperplasia.
Ishtat. Next, we'll talk about adrenal tumors and how to tell the good, the bad, and the frankly malignant.
Okay, Amr. Our next patient is a 52-year-old man who is undergoing an abdominal CT for hematuria. Incidentally, a 3.5 centimeter mass is found in his right adrenal gland. He's asymptomatic, but on further questioning, he mentions mild weight gain and trouble controlling his blood pressure. Lab tests show elevated cortisol not suppressed by dexamethasone, low ACTH, and mild hyperglycemia.
Ugh, the classical adrenal incidentaloma. For me, it looks like it's functioning in this case, and since it's smaller than 4 centimeters, could it be an adrenal cortical adenoma?
Yes, that's most likely the case here. Adrenal cortical tumors can be non functional, which means they don't make hormones, or functional, where they might produce cortisol and cause Cushing's, or aldosterone, which we call Conn syndrome, or androgens, leading to virilization, especially if it's a female.
So, in the case of adrenal incidentaloma specifically, we need to figure out if it's benign or malignant.
Benign adenomas are well circumscribed and encapsulated. They arise from the cortical cells, which is why they're cortical adenoma, and histologically, they show clear cytoplasm because of stored lipids. Remember, steroid hormones are lipids. And because they're benign, they also have low mitotic activity with no necrosis or capsular invasion.
Okay, so what can you tell me about carcinomas?
Adrenocortical carcinomas are rare but aggressive. They often secrete multiple hormones, usually cortisol and androgens, and present with rapid symptom onset like Cushing with virilization.
So, if a female patient presents with an adrenal mass plus Cushing syndrome plus hyperandrogenemia, this is an adrenocortical carcinoma until proven otherwise.
Yes, it should definitely raise your suspicion of an adrenocortical carcinoma. Histologically, adrenocortical carcinomas show pleomorphic cells, atypical mitosis, necrosis, and capsular or vascular invasion. These are all features of neoplastic or malignant behavior.
So, tell me about the specific syndromes or mutations associated with adrenal tumors.
Okay, we have some familial syndromes to keep in mind, like Li-Fraumeni syndrome with the P53 mutation and Beckwith-Weidman syndrome.
So, if you find an incidental adrenal mass on CT, what are the things you should consider?
You have two main questions to answer. Is it functional and is it cancer?
To figure out if it's functional, we need to assess all the adrenal hormonal axes.
You evaluate for Cushing syndrome and measure androgens. You measure urinary metanephrines to rule out pheochromocytoma. And finally, if they're hypertensive, you evaluate for hyperaldosteronism using aldosterone-renin ratio.
So, now that we have answered the first question of whether it is functional or not, what about the second question? Is it cancer or not? Can we tell just from imaging?
We have some very helpful criteria that will tell us whether the tumor is most likely benign or malignant. We look at three main things on CT, besides Hounsfield units and contrast washout.
So, as a rule of thumb, can we say bigger masses are more suspicious?
بالضبط. Masses larger than 4 centimeters have a higher risk of being cancerous. Then we look at the attenuation on CT without contrast. A mass with a Hounsfield unit of less than 10 is benign. And after that, we give contrast and assess the contrast washout, which is basically how fast the contrast enters and leaves the adrenal. The more rapidly the tumor washes out contrast, the more likely it is benign. But a mass with low washout is more suspicious for carcinoma because it's holding onto the contrast.
So, size, Hounsfield units, and contrast washout to tell if it's benign or malignant on CT. And you'd probably need to surgically remove these tumors, right?
Yep, treatment is surgical. Adenomas have excellent prognosis post-resection. But as you might guess, carcinomas often recur and may require chemo. In that case, we can give mitotain.
So, let's take another practice question now. Which of the following histologic findings is most characteristic of adrenocortical carcinoma? A. Capsular invasion with atypical mitosis. B. No mitotic figures or necrosis. C. Well circumscribed mass with clear cells. D. Pale eosinophilic cytoplasm with low nuclear cytoplasmic ratio.
And the answer is A. Capsular invasion with atypical mitosis. That's a key clue for malignancy.
Coming right up, we're talking about one of the most adrenaline-packed tumors in all of medicine. Hit us with a case.
Okay, Amr. Now, a 35-year-old man comes to the emergency department with episodes of pounding headaches, palpitations, and sweating. He says these episodes come out of nowhere, last about 20 minutes, and then he feels exhausted. Today, his blood pressure is 190/105 and heart rate is 112. You notice his hands are trembling and labs show high urinary metanephrines. CT scan shows a 4 centimeter adrenal mass.
So you said episodic headaches, and also he has hypertension, tachycardia, sweating. This is definitely pheochromocytoma.
Wahsh. The classic triad is headache, sweating, and hypertension.
Pheochromocytoma is all about those catecholamines.
Yep. Pheochromocytomas are catecholamine producing tumors. They secrete epinephrine, norepinephrine, and sometimes dopamine.
And this one is a medullary tumor, unlike the previous two.
Pheochromocytomas arise from neural crest-derived chromaffin cells of the adrenal medulla, and they release the catecholamines episodically, which is why patients often have paroxysmal symptoms.
So they're not hypertensive all the time?
They might be. About half of these patients have sustained hypertension, and half are intermittent, which makes it sneaky.
Interesting. How do you catch this tumor?
The best screening test is to look for metanephrines, either plasma-free metanephrines or 24-hour urine metanephrines and catecholamines.
So, Farahat, after you find the metanephrines, you need to find the actual tumor.
Yep. You localize the tumor with CT or MRI of the abdomen. If it's not in the adrenal glands, you should think of a paraganglioma.
And what is that paraganglioma?
Same idea, but outside the adrenal glands. They arise from sympathetic or parasympathetic paraganglia, anywhere from the neck to the pelvis.
And do they also secrete catecholamines?
Sympathetic paragangliomas, usually in the abdomen, almost always release norepinephrine's, but parasympathetic ones are usually non-functional and found in the head and neck.
So, if I remember correctly, pheochromocytomas had a classic rule of tens.
Yep, صحيح. 10% are bilateral, meaning they can sometimes recur. 10% are malignant, so most are benign. 10% are extra-adrenal, aka paragangliomas. 10% are in children, so the majority is in adults. And 10% are familial and associated with specific syndromes, although with modern genetics, it's probably more like 30 to 40% familial.
Let's talk more about those familial syndromes.
Pheochromocytomas can be part of MEN2A or MEN2B, and these are highly associated with a RET proto-oncogene mutation.
The RET mutation is a very high yield one.
Yes, definitely. Pheo can also be related to von Hippel-Lindau syndrome or neurofibromatosis 1. In the case of paragangliomas, the familial cases may be related to SDH gene mutations.
So back to pheochromocytoma. What does pheochromocytoma look like in histopathology?
Pheochromocytomas show a Zellballen pattern, which means nests of tumor cells surrounded by sustentacular cells. The cells are also positive for chromogranin A, synaptophysin, and NSE.
Do they need surgery?
Yes, surgical resection is usually curative, but it's very important to use specific medications first before surgery. Always start alpha blockade first, usually with phenoxybenzamine, to prevent an intraoperative hypertensive crisis. Then after alpha blockade, you can add beta blockers.
What if you give beta blockers first?
Oh, disasters. It can cause unopposed alpha adrenergic stimulation, leading to severe vasoconstriction and a hypertensive crisis.
Okay. So we always start with alpha blockers like phenoxybenzamine, and then we give out beta blockers.
Yep, exactly. Never forget.
Another round of practice questions. Which genetic mutation is most commonly associated with familial paragangliomas and increased malignancy risk? A. RET. B. MEN1. C. SDHB. D. NF1.
What do you think the answer is, Amr?
I believe It is C.
Perfect. C. SDHP. This mutation is a big red flag, as we said, in paragangliomas, especially if they're malignant.
And that's a wrap on pheo. We'll take next men's syndromes, autoimmune polyendocrine syndromes, and the full recap.
Okay, now, a 28-year-old man comes to the clinic for fatigue, difficulty concentrating, and frequent peeing. He says he's been drinking water constantly and waking up 3 to 4 times a night to urinate. He also complains of heartburn and occasional diarrhea. His family history reveals that his father had surgery for parathyroid tumors and something in the pancreas in his 40s. Labs show elevated serum calcium, elevated gastrin, and mildly elevated prolactin. An MRI of the brain shows a pituitary macroadenoma.
So, from what you said, the patient has hypercalcemia, excess gastrin, and a pituitary tumor, plus a family history of endocrine tumors. This is easily Men's syndrome.
Ash. This patient most likely has MEN1 or multiple endocrine neoplasia type 1. It's one of the inherited syndromes where patients develop tumors in multiple endocrine glands.
And if I remember correctly, they're autosomal dominant, right?
Yep, all the MEN syndromes are autosomal dominant with high penetrance. In the case of MEN1, there is a mutation in the MEN1 tumor suppressor gene which encodes menin, a protein involved in cell cycle regulation.
So, in the GI block, we touched upon men syndromes. Can you tell me the characteristic triad seen in men 1?
The 3 hallmark tumors are remembered with the 3 Ps. Parathyroid hyperplasia, leading to primary hyperparathyroidism and hypercalcemia. Pituitary adenomas, which are often prolactinomas but can also be growth hormone or ACTH secreting. And finally, pancreatic or GI neuroendocrine tumors, especially gastrinomas, insulinomas, and vipomas.
I remember these. And those GI tumors can be dangerous, especially because they can be malignant.
Absolutely. Gastrinomas specifically are often multiple and many are malignant. They cause Zollinger-Ellison syndrome with ulcers and diarrhea.
So, men 1 may have features of hypercalcemia, pituitary tumors, and GI neuroendocrine tumors.
Yeah, pretty much. Classic MEN1 features include recurrent kidney stones or bone pain from hypercalcemia, visual field defects or amenorrhea from pituitary adenomas, refractory peptic ulcers or chronic diarrhea from gastrinomas, and what's really important in MEN syndrome is a family history of endocrine tumors, especially in younger adults.
Okay, Farahat. Men 1, done. Now, what about men 2?
In MEN 2A and 2B, the problem is a gain of function mutation in the RET proto-oncogene. Remember when we spoke about it?
Yes, I remember now. And you mean to say that men 2 has 2 types, type A and type B, right?
Exactly. Men 2A may have medullary thyroid carcinoma, pheochromocytomas, and parathyroid hyperplasia.
So for men 2A, basically just think of thyroid, parathyroid, and pheo.
Exactly. Then for men 2B, medullary thyroid carcinoma, pheochromocytoma, mucosal neuromas, often in the lips and mouth, and these patients often have a morphinoid body habitus.
And medullary thyroid carcinoma is a very serious association. Is that what often kills men 2 patients?
Yeah, unfortunately, that's why if you diagnose someone with MEN2 and find a RET mutation, you must screen all of the family members, and if you detect a RET mutation in anyone, you must do prophylactic thyroidectomy because the risk of medullary thyroid carcinoma in someone with a RET mutation is 100%.
Oof. And okay, how do you go about managing the patients with Men syndrome?
Okay, so treatment depends on the tumor. For the parathyroid hyperplasia, if the hypercalcemia is severe, you need to do what we call subtotal parathyroidectomy, where you remove 3 parathyroid glands and a half, leaving only half a gland to do the job. For pituitary adenomas, you go for transsphenoidal surgery unless it's a prolactinoma, where you would treat with cabergoline first. Then, for gastrinomas or insulinomas, you need to resect or give proton pump inhibitors for the hyperacidity. And finally, for medullary thyroid carcinoma or pheochromocytomas, you go for surgical removal. But the key in men's syndromes is early screening in families, especially with known RET mutations.
So, PodBiters, just to make sure you didn't sleep throughout the episode, let's give you a question. A 22-year-old woman has oral mucosal neuromas and a marfanoid body habitus. Genetic testing shows a RET mutation. Which of the following tumors will she definitely develop? A. Parathyroid adenoma, B. Prolactinoma, C. Gastronoma, or D. Medullary thyroid carcinoma?
I think this question is pretty clear. D. Medullary thyroid carcinoma. This is classic men 2B, and because she has a RET mutation, remember, we said it has a 100% chance of developing medullary thyroid carcinoma.
Now that we're done with men's syndromes, let's flip from tumors to autoimmunity. Tell us more about autoimmune polyglandular syndromes.
There are two big types. Type 1 is rare, but classic in kids. It involves autoimmune hypoparathyroidism, Addison's disease, and mucocutaneous candidiasis, usually oral or skin fungal infections. It's linked to a mutation in the AIRE gene, which is crucial for self-tolerance.
Okay, Farahat. Saying autoimmune polyglandular syndromes is very hard for me, so I'm just going to say APS for short. And so I want to ask, is candidiasis usually one of the earliest signs of APS?
Yep. Chronic mucocutaneous candidiasis often appears in type 1 years before adrenal failure.
You said type 1. What about the second type?
Type 2 is more common, usually in adults. It involves Addison's disease and either autoimmune thyroid disease like Hashimoto's or type 1 diabetes. No candidiasis here in type 2.
Guys, I promise this is the last time. Let's give you a practice question. Which of the following is most associated with APS1? A. Medullary thyroid carcinoma, B. Mucocutaneous candidiasis, C. Pituitary adenomas, D. An insulinoma.
And the answer is B. Mucocutaneous candidiasis. Think fungal infections plus adrenal insufficiency plus hypoparathyroidism.
We're finally done. But, let's hit a final recap for the PodBiters.
Here we go. For adrenal hyperfunction, we have Cushing's syndrome, where there's too much cortisol causing a moon face, striae, and hypertension. There are two types, ACTH-dependent and independent. Diagnosis is with dexamethasone suppression and ACTH levels. Conn syndrome, on the other hand, is primary hyperaldosteronism, presents with hypertension and hypokalemia. Confirm with aldosterone-renin ratio and saline suppression.
Next, we went about adrenal hypofunction. Addison's disease or primary adrenal insufficiency is where we have autoimmune adrenalitis, hyperpigmentation, and salt craving. Treat them with hydrocortisone plus fludrocortisone. In secondary or tertiary adrenal insufficiency, we have low ACTH, no hyperpigmentation, and normal potassium. This is seen after chronic steroid use.
Next, virilizing syndromes, congenital adrenal hyperplasia. We have classic 21 alpha hydroxylase deficiency with salt wasting and ambiguous genitalia, or 11 beta hydroxylase deficiency with hypertension and virilization.
Moving on to adrenal neoplasms, we said adenomas are benign and well circumscribed, while carcinomas are invasive, pleomorphic, and have a poor prognosis.
Next, we spoke about pheochromocytomas and paragangliomas. The classic triad is headache, sweating, and palpitation. Diagnosed with metanephrines, you treat with alpha blockade first, then beta blockers, then we do surgery. Linked to RET and SDH mutations.
For the men's syndromes, men 1, remember the 3 Ps, pituitary, parathyroid, and pancreatic tumors. And men 2, it has 2 types. Generally, both types have medullary thyroid carcinoma and pheochromocytoma. The addition in type A is parathyroid hyperplasia, and the addition in type B is the mucosal neuromas and marfanoids.
Lastly, we talked about autoimmune polyendocrine syndromes, APS. APS1 has Addison's, hypoparathyroidism, and mucocutaneous candidiasis, while APS2 has Addison's plus thyroid disease or type 1 diabetes.
Okay, that was a mouthful, but we finally made it to the end.
Definitely, my friend. From cortisol storms to genetic syndromes, we covered it all.
Thanks everyone for tuning into PodBites. Whether you're prepping for boards, rounds, or just building your medical knowledge, one bite at a time. We'll see you in the next one. Have a good one.
Okay, so okay خلاص
والله بالغلط يا اخي هي كتبت بلوبرز فرحت عامل لا اسود. Okay, so let me give you my analysis. Ambiguous genitalia, salt wasting, and that sky high 17 hydroxyprogesterone in a newborn. This all lets me
let me give you my analysis. ما ادري
يعني اني
احلل الاناليسيس
مكتوب قدامي. المهم والله بوريكم